You everyone for coming today. We'll be discussing palliative care and advanced care planning in patients with chronic kidney disease and end-stage renal disease. I have absolutely zero disclosures. And then for learning objectives, we have quite a few today. So first, we're just going to differentiate between palliative and hospice care, recognize the growth and constraints within palliative to those specialties specifically. Then we're going to review the mortality data and the annual data report from 2023. Provided by the USRDS and the National Institute of Diabetes, Digestive, and Kidney Health. We're going to just assess surveys because, understandably so, when it comes to palliative care, it's very hard to do prospective studies. So most of the data is qualitative, and they're surveys to patients and providers. So we'll be assessing surveys concerning the competence of nephrology fellows, and nephrologists have leading end-of-life discussions. We'll summarize and analyze patients' reviews of these discussions and a proposed method to increase confidence in surrogate decision-making. And then lastly, we're going to discuss kidney supportive care and evaluate a proposed strategy to facilitate advanced care planning discussions. So I have to continue the theme of starting off with a quote. So I went back to Hippocrates, cure sometimes, treat often, and comfort always. Okay, so identify the role of palliative care and differentiate between hospice and palliative care. So why am I taking the minute here just to differentiate the two? Well, between residency, fellowship, talking to other residents, talking to fellows, talking to patients and their loved ones, I've noticed that there is definitely a discrepancy in what they believe the definition of palliative care is and what palliative care is compared to hospice. They all more or less think that hospice is palliative care and vice versa. So I thought a good way to illustrate this was just by going to Dr. Google and just typing in palliative care. I do not know why palliative care is bad as the top option. That was concerning, but the rest of the searches are consistent with what I expected, that people were just trying to learn the differences between palliative care and hospice. So, what is the role of palliative care? Essentially, the goal is to improve the quality of life of our patients and their families. It can be provided with curative treatment. It's not for terminal conditions, that's for hospice, but specifically along with curative treatment. The patient just needs to be diagnosed with a quote unquote serious illness or a life-altering illness. That does include COPD, that includes cancer, that includes Alzheimer's, Parkinson's, and chronic kidney disease, for example. The goal is to provide relief and from symptoms and stresses of these serious illnesses, and it's based on the needs of the patients. So one solution does not fit all. This is much more on a granular level about what palliative care has to offer. It's neither meant to hasten or postpone death. It's much more comprehensive. It's going to integrate both psychological and spiritual aspects of patient care. And it's a team approach, not just a palliative care physician, but there are other like nurse practitioners, and the supportive staff is more comprehensive than what we would be able to offer ourselves. It's not as expensive as the hospice, which we'll talk about in a minute, but there are resources that you can offer your patients when they are referred to palliative care. And another big thing is that it affirms life and regards death as a normal process. It tries to take the stigma out of death and kind of give control of the patient and their serious condition back to them as much as possible. Like I mentioned before, examples of serious conditions that a patient can be referred to palliative care if they're diagnosed. So what is the role of hospice? The big thing is the terminal phase. So a patient has been diagnosed with a condition where they have less than 6 months to live per Medicare. Medicare will cover it if the patient is expected to have less than 6 months to live. And they have an interdisciplinary team that provides care in an encompassing way to both the patient and the patient's families. And from what I understand, hospice care and the resources available to the patients and their families up until the patient's death and up to a year after the patient passes, which I think is very important, especially in the bereavement period of the patient's families. So the team comprises of physicians, therapists, nurses, counselors, and then things that stand out, spiritual bereavement counselors, and just the hospice aid workers in general. And specifically, this is just a graph differentiating the two. We're not going to go over the whole thing. I just wanted to demonstrate that this is from the National Hospice and Palliative Care Organization. We're going to focus on just what the services are for a second and differentiate the two. So with hospice, you have a 24-hour person on call. You have in-person visits. You have the Medicare equipment. You have continuous care at home and your respite care. You can see that the services offered to patients that have palliative, that are receiving palliative care, it's much less, but they are still getting pain and symptom management. They are still getting to going into advanced care planning and referrals to community resources. So what is the current state of palliative care in the United States? So since 2000, it has definitely been growing. So palliative care in itself was born in 1974. It started off in the United Kingdom. It came out of hospice care, actually. So the whole thing started related to cancer treatment in patients in the United Kingdom. They realized there was a need for care between patients that had terminal illness and was being diagnosed with cancer. Patients needed support. So that is how palliative care was born. And then I think in 76 or 78, it was brought over to the United States, and then it was palliative care and hospice was recognized as its own field essentially in 2000. So the field has been growing in the United States since then, and then specifically for 50 beds or more, which is an all-encompassing figure. So how are we doing? And it's broken down by region, more or less. So this is all that I include so this is all from the Center of Advanced Palliative Care, and every couple of years they kind of assess how states are doing. So growth in palliative care by region, generally speaking, I just wanted to bring attention to the East Southern Central and West Southern Central areas specifically, and that they are lagging behind. While there is improvement, they're not doing as well. When it comes to grades specifically, what they're talking about includes how many palliative care providers, whether it's a MD or if it's a APRN, per 100,000 residents in the state, as well as whether the states have inpatient hospice available, depending on the bed size and the resources in the community for these patients. So this is broken down by bed size and nonprofit, for-profit, and public, and I don't think it's entirely surprising that the for-profit hospitals, smaller or the more rural areas are, palliative care isn't necessarily as accessible, just because palliative care is not the most lucrative field. You're supporting the patient, but how are you going to be making money when it comes to palliative care? You're not necessarily going to be making a lot of money. You're not doing procedures, for example. So there is a lack of incentives to hospitals to provide palliative care for their patients other than doing regular patient. This is broken down by more or less the bed sizes and by region. And once again, generally speaking, the larger hospitals do have palliative care available, but the more rural hospitals, as you go smaller in size, resources are lacking. So what are the gaps? Urban versus rural. Hospitals in urban areas are generally do have more resources, whether that's just because of the fact there's a greater patient population, therefore they feel the need to have palliative care available. The availability varies by region, and then lack of incentives and the accountability to have this access for our patients. All of that is an area of need. And then, unsurprisingly, there's a lack of research in palliative care and whether or not we're doing right by our patients in terms of our treatment. It's kind of hard to assess that. And then lastly, which we will be talking about, is insufficient training in symptom management, family and patient support, and then communicating difficult topics with their patients and their families. So why is this relevant to us specifically? Now we're going to go over the mortality data in our patient population. Right. So this is all from the annual report that was put out in 2023 from the ESRD and the NIH. So we have all ESRD, we have dialysis patients, and then we have the transplant patients. You can obviously understand what happened around this time period that increased the mortality rates in all patient populations across the board. But generally speaking, so this graph is representative of per 1,000 patients that are on dialysis or that have had a transplant. So, and this is all-cause mortality, any stage of ESRD, whether you've had it for a year, whether you've had it for 10 years. But the rates in 2011, for example, for patients that were on dialysis of mortality was roughly about 172, I believe, per 1,000 patients on dialysis. And through 2019, that rate slowly decreased to about 162, and then the pandemic happened. And the rates increased across the board. All right, so the top left is ESRD, the top right is patients on peritoneal dialysis, and then on the bottom are patients with transplants. I'm going to focus primarily on the left, but I wanted just to put this up here to show that they do, the registry does have data available for all three types of patients. And honestly, though, the trends are similar across the board, and that the patients that are 75 and older have a higher all-cause mortality. And then essentially, the younger the patient, the lower their all-cause mortality is over the years. So this is broken down all-cause mortality by area. The darker the region is marked on the map, the higher the rate of mortality is. So Texas, Oklahoma, Kansas, Mississippi, Tennessee, Kentucky, West Virginia, roughly speaking, have higher rates of mortality. They also have more rural population generally. So why am I bringing this graph up? Well, obviously not causation whatsoever, but I did think it was interesting pulling up the
Question.
Yeah.
What is that area in Florida that starts in the middle?
It's I-4 corridor.
I just make sure it's not danger, right? We don't know. Okay.
I didn't. It's not game was specific.
Okay. We got the picture. We're good.
Okay, so this graph is a depiction of the grades that these states got in their palliative care resources and available to the community from the CAPC. If it's dark blue, that means these states got a grade A. So inpatient palliative care options were very plentiful. Outpatient resources available, many providers. There are enough providers that made no satisfaction. Light blue is a B, so Florida got a B. But then purple is C. In other words, more or less resources, and orange is essentially they failed. And there is it's not perfect overlap, but a lot of the states that have higher all-cause mortality are also lagging behind in terms of palliative care resources in our patient population, which I thought was very interesting and upsetting, to be honest. Okay, so back to our mortality data. So all-cause mortality for patients that were after initiation of dialysis by treatment modality. So this is HD, this is PD. So for example, what they did is, so 2007, for example, so year one would be 2007, 2008, 2008, 2009, so on and so forth. And then if you look at 2017, this would be the year 2017, this would be 2018, 2019. In other words, years after they've been initiated on dialysis and all-cause mortality across the board. Now, the 2019 data is obviously also going to be confounded by the pandemic, and so will the data for the 2017 years after they were initiated. What I thought was interesting related to the pandemic is that the 2019 rate of mortality state kind of are almost level, but the 2017 cohort, their mortality definitely increased with relation to the Now, adjusted survival incidence of ESRD patients, patients over the first 5 years. So now the X column is going to be months, and it's the same structure where 2007, you're going to have, this will be the first month of dialysis, this will be a year, so on and so forth. So almost across the board, about 5 years after these patients have started dialysis, the adjusted survival rate is roughly 40%. You can see with the patients that were initiated in 2017, roughly speaking, about 3 years, their survival rates decreased, which again, related to the pandemic. But still, more or less across the board, 40% of patients have a survival rate after 5 years. Now, this is going to break it down by the age group of our patient population after 5 years of being on dialysis. Patients that were 18 to 44 years of age when started on dialysis had a survival rate of about 60 to 70%. And then you can, I don't have to go through each and every one, but this was very clear and upsetting, whatever word you want to use to describe it. But this, I was very surprised at, that there was only a 20% chance of survival 5 years after starting dialysis in our older patients, regardless of what year they were starting dialysis. It's not as if the data was improving or it wasn't improving over time. There's still roughly about 20% across the board.
Thank you so much. Can I just make a little comment? Sometimes I bring this data when I talk to the inpatient teams, right? When we talk about what's tertiary is, how we would like to come off dialysis if we can, we want to minimize the time on dialysis itself, if possible during the inpatient, right? We change the hemodynamic stress on recovering kidneys, for example. and these are the data I bring up and say what survival. Becoming ESRD is a getting with colon cancer, right? And people don't really realize that, even going to finish with breast cancer. I did not realize that before I did my pharmacology training. Just how significant ESRD is for prognosis, right? Not just quality of life.
I didn't either, and that's why I wanted to go over.
Thank you so much for doing that. Yes, I truly just, I just spit out this data and said like 50%, half of your patients will be dead in 5 years. Big deal. It's a big deal if you can take them off dialysis, right?
I have a question. So if you go by the general population who is 75-year-old, what's the percentage of survival at 5 years?
Okay, like 2 minutes.
Well, because it look like 75, you know. Okay.
You're getting ahead.
I'll flip them for survival again.
Okay. So, we'll get to this tab in a second. All right, so this is looking at the actual number in itself, but this is expected remaining years of life and prevalent patients. And now I'm not entirely sure how they calculate specifically 5 years for patients that, it's in 2019, 2020, so there's projection involved. But we'll go back to that patient group that was 75 or older. 3.7, 3.5, 3.3, 0.0, 3.2. In other words, it is you're putting the patient on the clock once they start dialysis, whether they were already there to begin with, understandably so. But the question we'll be discussing will be: you're starting dialysis, prolonging life, but is that what the patient needs? Okay, Dr. Santos. So now we have the general patient population. So we had said 20% after 5 years for patients that were 75 or older, right? So now the general patient population, 75 or older, 11.6, 80 to 84 would be 8.5, 7.3, and then 85 or older would be about 3 to 4 years or so. So there is a difference between patients that are on ESRD versus the patients that are not on ESRD. And then this is just the adjusted mortality rates of patients that are end-stage renal disease versus just patients that that have other comorbid conditions. So you can see that the rate of mortality is drastically higher in patients that are on their dialysis dependent compared to other comorbid conditions. And then what I thought was interesting was patients that have received a transplant. The only conditions or comorbid conditions that had a higher rate of mortality were patients that had heart failure, patients that had acute MI. But otherwise, cancer, diabetes, and stroke had a higher adjusted mortality rate than patients that had received a transplant, at least in this older patient population. Okay. Now, briefly, we're going to talk about hospitalizations and nursing facility stays after transitioning a patient from CKD to ESRD, and it's just an observation study. So this is all from October of 2011 to October of 2012. Patients that were at continuous year of Medicare A and B that were 67 or older, and they're going to look at the days that the patient spent in the hospital or in a nursing facility within that first year after starting dialysis. And the patient population here is roughly about 28,000 or so. So they were very proud of this graph. It was very hard to understand. So just look at the numbers. The numbers are much easier to interpret, but we have ages 67 to 70, 71 to 75, 76 to 80, and then greater than 80 years old. So we'll look at the survival rate. So in 67 to 70, this is all cause mortality and comorbid conditions. They haven't adjusted for that. We'll look at that in a second. But survival rate in patients 67 to 70 would be 76, and the survival rate as the patient gets older decreases with it. So starting dialysis. So patients that are greater than 80 years of age, their survival rate was 58%. They spent about 66% days in the facility. Now, the facility days increases incrementally, but it's still an increase comparatively to the patients that were younger. Okay, now on the left, you're going to see 67 to 70 greater than 80 without cardiovascular disease, and then on the right, you're going to see the same group but with cardiovascular disease and the survival rates and the need for facility. So we're going to focus on the greater than 80. So 77% without cardiovascular disease survived within a year. 72% were in a facility. Meanwhile, if patients with had cardiovascular disease, the survival rate drops by 22%. And 92% of them required stays in the facility. Okay, now the comorbid set of cardiovascular is dementia. Right? So I'm going to focus again on the patients that were greater than 80 years of age. 59% survived, and 88% were in a facility. Meanwhile, patients with dementia, only 45% survived within a year after starting dialysis. And 98% of them spent time in the facility. All right. Now we're going to change gears a little bit. Look at a self-assessment in our kidney supportive care, how we think we're doing or where we think we need some help on. There's a few studies on this. But first, there was a simple survey from 2006 to a clinic in, I think it was the Northwest, where they just asked nephrologists how prepared they were about having these discussions. So there was a very well prepared group and a group that said that they were not very well prepared. What I thought was interesting was if you look at the years of fellowship or when they completed fellowship, the nephrologists that have been practicing for longer obviously felt as though they had more comfort leading these discussions. Meanwhile, the nephrologists that were more freshly completed their training and were generally younger had more difficulty or did not feel as comfortable leading these discussions with their patients. That's all I wanted to focus on. Oh. Okay. All right, now, in 2003, a survey, and I think this was affiliated with one of the North Carolina schools, but or hospitals, but there was a survey sent to the nephrology fellows about how comfortable they were about leading these analytic discussions. What I thought was interesting in this 2003 survey was that 99% of them said it was important to have these discussions with their patients, but half of them said it was important for them to be the ones to lead that conversation. They said it's important to do, but it's not my responsibility. 10 years later, they did the survey again. And that number changed. It was the same across the board. 99% said it was important for them to do, and 99% of them said that it was our responsibility to have that discussion, or at least start the conversation. And then what I also thought was interesting was that they asked them generally, so the p-value for the last three questions are not great, but they thought the conversation was depressing. So whether or not that may have contributed to why they were uncomfortable, I can't draw a conclusion off of it. I thought it was interesting. Oh no, it keeps freezing. Okay. All right, so they asked these fellows how comfortable they were and with the teaching they got for patients that were on dialysis, patients with distal RTA, and patients that were at the end of their life. So there was a lack, I guess you could say, of training about leading these discussions, and then they felt a little bit more prepared to have these discussions. And again, this was just asking them a simple question of, have you gotten teachings? Are you prepared to have these conversations? They didn't really dive too much more into the data. They did ask, though, how many of them conducted a family meeting? How many were they observed while leading these family meetings if they got feedback? So I think the median of the fellows said that family meetings, that they had family meetings. And then the observation rate goes down across the board, which I think makes sense because the more family meetings that you have, the person that's observing you is comfortable with you leading those discussions, don't necessarily need to be attending more than 10 of those conversations for the trusted fellow to start those conversations. But I did think it was interesting that 50% never had any feedback whatsoever on having a discussion. It's just, if you were being observed, was there feedback about how to improve or what you did well in the conversation? That's all.
Should we lead the conversation, then the attending gives you the feedback on how you did?
Yeah. Yeah, okay.
So they haven't done any, send from 30-50% review of feedback, so they say never. 30% never did the assessment, but 50% of those who did it didn't get the feedback.
So
It includes.
the denominator is those who
Right.
had the meeting. Among those who had, then that's 50%.
Now, what are the patient's assessments of their kidney supportive care? Okay, so this is from a study or a survey in 2010, end of life care preferences and patients' perception of their chronic kidney disease. So the average age of these patients were about 68. 40% to 41% of them were not on dialysis yet. 38% of them were on HD, 12.5 on PD, and 8.7 on. The education level for these patients, about 62 to 63% of them had a high school level of education. So, how informed are you in regards to your medical condition and medical condition will change over time? About 86 to 87% of them said they were very or somewhat uninformed. So 12 to 13% said either unsure or they were somewhat or very informed about their condition. Now, how do you see your health in the next 12 months? 52% of them said it's not going to change. 30, roughly 30% said that their chronic kidney disease or their ESRD is going to improve in the next year. And then 69% did not know what palliative care was, and then roughly 50% did not know what hospice was. So you can't draw conclusions from this data, but you could at least notice that there is, whether it's the level of education or whether it's conversation with the patients, there's something missing in the sense of their ability to understand the severity of the patient. We're gonna only focus on the top couple questions because this is a busy chart, but essentially patients said it was important that it's important to them that they were informed about their prognosis, that they have information about their condition, about what their treatments are, including withdrawal of dialysis and having their physical symptoms treated. Also a busy slide, but we're going to focus on this, where they ask if you are currently receiving dialysis, do you regret the decision to start dialysis? 60.7% of them said yes. Now, I don't know how long the patients have been on dialysis for, you don't know who's start, there's a lot of things that we're missing from it, but that's very, again, a lot of this information I just was caught off guard, including mortality data and everything that we're reviewing, and that's why I'm having to talk today. We have the importance of making sure we're doing everything that aligns with the patient's goals.
I wonder if they think their kidney function will recover without dialysis. That's why we do that. Not necessarily the. Or living person not doing that.
So now this is a health outcome priorities, older patients with CKD, and concordance with their nephrology provider's perception. So in other words, we ask these patients a couple of questions, including what are their priorities? Do they want to maintain independence? Do they want to, is their goal to stay alive? Or is it more or less symptom management? And then they ask the nephrologist who's caring for these patients, what do they believe the patient's priorities are? Yeah, so this is from a single academic clinic. I think this is from Vanderbilt in November of 16 through January of 2018. So roughly about 271 participants ultimately participated in the survey. So the way this graph is set up is it's maintaining independence. So up to 50% of these patients picked maintaining independence as their number one priority. About 38 to 39% said staying alive was their number one priority. And now the sub blocks within the bar graph is that this is their second choice, because it wasn't just pick one, it was rank them 1 to 4. So staying alive, unless you pick staying alive as your priority for these patients, staying alive ultimately, if it wasn't number one, it was number 4 for the most part. Most people cared about maintaining their independence or making sure that their symptoms were alleviated, they were comfortable. But staying alive was only the priority for 38%. So this was just they also did a survey, or they asked the patients they asked the question to assess their functional independence and how that essentially contributed to what they ended up selecting for their option. So patients that felt as though they were functionally independent, had good functional independence, or fair, one for maintaining independence, but a little bit less for staying. Yeah.
So I think there is an inherent problem with this particular type of surveys. And that inherent problem is, I think it is, none of these surveys have clarified the patient's perception of 1, 3, and 4 in absence of 2. You see my point? So I think there has never been and at least to my knowledge, we don't have a study which says that once they understand what the implications are, when dialysis is needed, what are the implications? And at that point, if you do what is important for you, because there are a few studies like this which suggest, and there is a significant more literature which says that a lot of patients want conservative care. But when you see, and this, all of you have seen this in your practice, when push comes to shove, when this person gets into pulmonary edema and ends up in ER, by default, either them or their family end up starting dialysis. So there is an inherent problem with this type of survey where they don't clarify, the investigators don't clarify whether the 1, 3, and 4 are independent of 2. That's all. And there is it's a technical glitch.
I mean, and also in acute situation, the stresses of the situation and knowing that it's emergent. Patients' goals are changing. Right. So I think that's why, generally speaking, they try to have these discussions when patients are more stable. And then the goal is that when they become more unstable, whether it's more death is more imminent, the hope is that the goals would stay the same across the board. But you're right, there are no studies that.
But there are a good number of studies that the selection or the choice to reality, that is the use of a modality, and let's call it conservative care as a modality. There are decent studies which show that selection to use, there is significant discordance there. So there is a significant concordance, and you do the regression, it comes very well. But there is also a significant proportion of patients that don't go towards that selected modality. And I think there is a critical gap there where people haven't figured out who are the people which actually are digressing.
So this chart, to go back to this study, this chart asked the providers what they believe their patients' goals were. So what they did was the provider, they did not know that they were going to get the survey when they saw the patient. Once they left the room with the patient, they then provided this and asked to rank the patient's goals, what they believe the patient's goals would be, and the patient was done the same. So the way this chart is read out is, so for this column here, these are all the patients that had selected maintaining independence as their #1 priority. And then from left to right are the provider picking what they believe was a patient priority. So in other words, there were 133 patients that had said maintaining independence was their most important priority. The provider said 50 of their patients had picked a priority, 50 here, 31 here, so roughly 94. In total, they had selected, but only 18.5% they were correct. That's how that goes. Okay, but the point of this is just to show that there is a discordance between what the provider believes the patient, what their goals are, what the patient believes, what the patient is saying at that time their goals are. And this is just so this study was survey was flawed, to say the least. But I just thought that it did illustrate that there is some discordance. So the single center study, if you looked at the previous study they done that had the 66 or 68% of patients at high school level of education or less, they said 64% of patients had at least college education. And then if there's concordance or discordance, it doesn't necessarily mean that you're going to have an improvement at the end of life quality. It just means that there's a discordance. You can't necessarily draw conclusions from the discordance and how it's going to change things. Okay. So the SPIRIT trial. So essentially, this was a trial that assessed having conversations with patients to try to make sure that their goals, or what they said their goals were in sync with their surrogates. And they compared it to patients that they did not end up having this conversation with. So more or less, it was broken down into 2 different sessions. The first session was 45 minutes. 2 weeks later, It was 15 minutes. So the first session, they talked to the patient and their surrogate, assessed the cognitive, emotional, spiritual representations of their illness, their prognosis, and what their end of life care would be. They wanted to make sure that the surrogate understood what the patient themselves were saying, and then they provided a goals of care document at the end of the visit for the patient to fill out, not then, but to go home and come back 2 weeks later. So the 2 weeks later, the patient came back with their surrogate. They had answered any lingering questions. They had filled out the goals of care document, and then they reviewed it to make sure there was no ambiguity in the document. So what they found was that the congruence between what the patient was saying and the healthcare surrogate was greater in the patients that in the group that had this intervention. Then they followed the surrogate through, I believe, up to 3 months after the patient had passed, and the anxiety level for those surrogates was much less than the surrogates in the group that did not get the intervention. The rate of the bereavement and the depression and PTSD scores were similar, but the actual anxiety that the surrogate had was less. How are we doing? Okay. All right.
I have a question.
Yeah.
What was done to the control group of that study? They just get the paper and then sign it?
So there was no special conversation. It's what they were practicing at that. Okay, so how do we approach this difficult transition period? So HEKD had put out I think 15, 20 page core curriculum that essentially provided a not comprehensive, but discusses physical, psychological, social, and spiritual existence, and a guideline or a roadmap for fellows or nephrologists to implement or how they could approach their patients. But kidney supportive care specifically, it's symptom management. It can be done across any of the care settings with time. So what does kidney supportive care encompass? Symptom goal, symptom management, communication, the interdisciplinary team, comprehensive conservative care, which we'll briefly talk about in a second. But essentially what it is, it's CKD care without initiating dialysis and trying to maximize quality of life in the patients. And then preparing for end of life care. So we've talked about a good amount of this. Specifically symptom management, we've been talking about for the last 5 weeks. So I didn't want to spend too much time on it today, but yeah, it's obviously a very important part of kidney supportive care, generally speaking. Okay, so this is a survey.
Fatigue in these patients.
I did not look into what.
Apart from fluid overdose, I really don't know. That may be depression. But apart from that, what do you do with it? Dry mouth, just have some ice.
Ice cubes.
Several cups a day.
But I want to go back to what their short term. Many of survey studies by definition are the lowest quality because of the inherent harm. But when it comes to conservative management, we try to avoid telling them that it means you die. So we try to just tolerate by saying that the management, symptom and all those. So as the Shukla mentioned, the comparator is that, oh, I had not had dialysis, I would not have been coming here 3 times a week. That's what their mind is. So for the same, for the symptom management, when we tell them that there is not a lot that we can do for most of these symptoms, but they are not being diagnosed. And unfortunately, actually, some of them, when they get dialyzed, some of the symptoms stay.
So when it comes to the conversation about death with these patients, if it's a patient that's in an acute situation, I understand. But if you have a patient that has chronic kidney disease that you've been seeing over a period of time, are you also not having that conversation? Or you're not saying that if we ultimately don't start dialysis, we'll die? Or are you feeling more comfortable with these patients because you've been seeing them over years?
You see, last week, I brought one of my CKD patients here for the medical students. Every year they come, it's called patient presentation. They come, I bring the CKD patient. This CKD patient was a PD patient that then ended up being transplanted at the age of 70 something, actually. Right? So when he was explaining to the medical students, he told me when I went to the CKD education class, they gave me 3 options: HD, PD, death, and I chose PD. Right. So this is how they perceive it, those who are a little bit more, I guess, intelligent. Those other ones, we try to hide it, that's the reality. That's what Dr. Shukla was saying, many of these questions are not standardized, you don't know what exactly they explain to them, what is conservative management.
The other kind of patients, there is always, when kidney disease progresses to a point when your physical function, whatever's left from your kidneys is not supporting your body enough, there are a few choices, right? There's a full menu. One way is to do nothing and let the nature take its course, right? Kidney disease, advanced kidney disease, and then stage disease used to be deadly, immediate, right? Pretty soon, right? But not within years, but less than that, if we do nothing. And then there are choices of what we can do. These, we can, of course, it's good to be on the route to transplantation and get the kidney. In the meantime, we can bridge you, right? If you're a candidate, we can bridge you with a machine doing some of the jobs. Or, of course, we can sometimes, the machine, the dialysis becomes a long-term care destination. So those are the choices. Those how we plan for the future. It's better to plan in advance. It's better not just having to be a surprise or an internal surprise in the ER or something. On to the things and become a team. Work with it. We every visit. It's these continuous. Stage 5 for and late stage 4. I don't know because I'm sure everyone has their own things to say. I did 6 weeks of Palliative, full disclosure, during my residency in medical school. See, the entry, it never goes away.
All right, so this is just, so for the, for this specifically, when it comes to how patients are feeling, this is an example of how they assessed the patient's symptoms, and then they had them scale it 0 to 10, and then, they could just mark the areas where they're having symptoms. Okay, supportive care, like we have kind of started talking about already. It's maximizing quality of life and aligning all care with the patient's priorities.
I think let's close that particular discussion. I think many of these, and remember, it is always difficult to evaluate a continuous variable in a categorizing manner. It is further difficult to evaluate multiple continuous variables in a single categorizing manner. I give this election analogy. You have two choices. You have to vote for one or the other. You can decide there are 25 issues which are important to you, which are driving your point of view. But eventually you get to vote for one or the other, right? And at least in US, at least. And that's what this is. So the goal sometimes ends up becoming in these discussions is how do you discuss about these 12 important things to that particular patient, which are all on a 0 to 100 scale or whatever artificial scale you want to become. But that's what the scale is. And how do you drive that final message out of that to say, this is my decision? And those scales keep changing amongst themselves. So the decision making is such a, I don't want to use the language here, but it's just a storm, it's a chaos. And it just is, I think most of these studies, simplistic studies, miss that marker. Nobody has tried to go into sort of a slightly detailed aspect or objective aspect of it. I think most of us understand objective more than qualitative, so that's the problem. Sorry.
No, you're fine. Yeah, so then who is a candidate for comprehensive conservative care? It's anyone that has that meets the criteria. And there is no set criteria. This is shared decision making with patients' goals, right? Because we're ultimately trying to help our patients, and if they don't want to proceed with aggressive care, then they don't want to proceed with aggressive care. Okay, so this was just a simple chart about what they recommend, and this was from that curriculum that the AG, KD had put out, but what are aspects that we can manage specifically, and then at what point should we get palliative care involvement as to drive the bus? And they have recommended that once there's a further assistance with advanced care planning and then the life care is needed, that a referral could be used. All right, so want to just briefly talk about hospice, and then how many of our patients ultimately do end up on hospice. So Alzheimer's, cancers, Parkinson's, higher up on the list, but end-stage renal, roughly about 24,000 patients. This is data from Medicare. So about 24,000 patients all ended up transitioning or withdrawing from dialysis and started on finishing hospice. So survival after dialysis is continuation of hospital enrollment. After we kind of talked about it yesterday, I wanted to actually put the data in. But they had several hospice networks across several different states. They had these patients kind of rank different important indicators of function, including ambulation, activity, self-care intake, and this level of consciousness to kind of see between patients that are end-stage dialysis or end-stage renal disease that then transition to hospice versus patients that were hospice that do not have kidney disease. So more or less, the patients that discontinued. So the patients that hospice that discontinued dialysis was roughly about a little less than 2,000. Non-renal hospice diagnosis about 124,000. But the higher the score for the palliative performance scale, the more functionality the patient said that they had at baseline. So you have about 67% of patients that discontinued dialysis had a functionality score more or less of 20 or less. So in other words, they were not independent. So average mean is about 78. Like we had just talked about, almost half of the ESRD patients had a score less than 20. The patients who discontinued dialysis had a mean survival of 7.4 days after their hospice admission and median of 4. But hospice patients that did not have a kidney non-renal diagnosis had a mean survival of 54 days.
More questions.
So
function.
question, did they tell or give the percentage or number of dialysis patients who withdraw care and died within 7 days? Were they in the hospital or in the community? Because I'm wondering if they're just all dying in the ICU and the
Yeah.
family withdraw care,
They
and
wanna
that's
actually-
counted as they stop dialysis.
Majority of the time.
Because if they died in
some
4 to
ICU
7 days, this is not community patients,
That's
right?
right. If
Yeah.
you see the
Yeah.
previous slide, there is no home hospice. If
Yeah.
you see the distribution in a home,
Mhm.
there's very few home patients.
Yeah, so,
Compared to hospital 52 and nursing home 19. So pretty much 70% are nursing home and
Yeah.
hospital patients.
Which makes sense because most did not transition to hospice. When dialysis patients, right? 1.3%.
no, this is after withdrawal from dialysis, so it's just like everything is lost when they stop everything. Basically, that's the
They
scenario.
are much sicker.
That's
than
what they are
community
serving.
patients Without dialysis being in hospice.
Right, so they didn't have outpatient hospice to do it, so they had this while they're all inpatient and deciding to withdraw.
Another question, I'm not familiar. Is it required if somebody has to be on hospice to have a DNR in place,
Yes.
right? That's what.
But I don't believe hospice covers dialysis, right?
Ah, that's a good question. It used to be that. But now we can make a provision. So hospice 6 months or less to live. Right, and that's the condition. Now, someone else sneaks in, which is by our consent for lifelong consent for dialysis. It does say hospice, but not specifically without dialysis.
It's not covered by Medicare, man. They will not do, they will not do any
Yeah.
therapy that prolongs life.
Yeah,
You can do IUF, you have inpatient hospice, you can do ultrafiltration for hospital cost or comfort measure.
Yeah.
But if you are at a hospice facility, they will not cover anything that prolongs life, including blood draw dialysis.
I know that VA for sure. I know I've known many patients on hospice with dialysis for sure. So
But the inpatient-
actually, VA.
Inpatient, right?
Waking is outpatient.
No, no.
But
there
in
is
the
the-
VA, they don't palliative with concurrent hospice.
Maybe.
They have
Maybe
both.
VA is different. I'm just talking, I
Yeah.
don't work at VA, so I'm talking
do both.
outside of
Then I think
So this
the regulation on this are changing, so we have had a few patients which are on ongoing PED or dialysis. And there is a quote unquote like this is new category coming in, which is hospital. I don't know, I always, yeah, I always get confused that which one is hospice and which one is palliative care. But they're one of the two with concurrent dialysis, there is a category coming. That means you are not withdrawing everything, but you are expecting this to last less than 6 months. And that sort of is a category coming up of our day. So we have had a couple of patients accepted by home hospice people. And again, please excuse
And
me, I don't know.
Medicare continues to do dialysis.
The patient continues to do dialysis, but they qualify under hospice or palliative
No,
care.
but wait, once you're in hospice, it's all hospice umbrella, like all the costs come out from hospice umbrella. Like you're not, that's what Medicare allows you to.
We
do
didn't
hospice,
find out,
you don't
but we
pay.
know that somebody, so there is this new category coming up. VA for certainly does it. We just had a yesterday, VA started palliative care for a while. Now they are hiring a few more people if somebody wants to join. And they are trying to engage nephrology, but they themselves are doing the exact same thing. But I think Medicare also, there is a new category coming up. I don't know the legality, but I've had 2 patients on it, so.
I have a question. What happens if the patient outlives their 6 months and they did not die? Can you keep on recertifying?
Yeah. Yes.
And there's no limit, right? No penalty.
Well, a penalty in the sense.
I mean, patient will die 3 times already. Say he will die 3 times and the patient's not died.
No, no, this is the same as, so in nephrology, for example, in dialysis, you can start people above 15 GFR on dialysis. And you can have a small portion of your patient recover the renal function, even though it is certified ESRD. Now,
Is
there is
there a
no,
penalty if you have more than 3?
there is no penalty, we haven't tried. When our population, if half of my population goes that way, I don't know what they are
I
going to
thought you
do.
would be delisted by Medicare or something.
That's
no?
what.
They will delist you if you keep on certifying and they keep on recovering.
No, so if my rates become that high, it hasn't gone so
I've
far.
heard that.
Collectively, we have been great. So
Yeah,
that
but-
I don't have 10% of population recovering renal
Yeah.
functions. But if that happened, my assumption is somebody is going to flag some.
That's what I've heard. That's why some people don't want to certify
There you go.
ESRD in the hospital because if they recover and you accumulate, you will be
Yeah,
delisted.
yep.
I don't know that. I don't know that.
1%.
Right.
Okay.
Okay, how many slides you? We got 5 minutes.
That's fine, oh, we're pretty much, yeah,
Oh.
okay.
That was concurrent, that's what the she was saying.
Yeah.
Hospital plus dialysis.
But I noticed, like, we have a patient on definition, I'm not sure, definition of doctor is running, the palliative doctor is like, they are not covered by office. Office is going to provide some help, like nurse visitations, pain control, but they're going to continue the same plan doing dialysis.
Right, I don't personally have, it's not implemented yet, in the future it may be implemented. My personal opinion is, it just doesn't make sense to me, like, you're gonna go into a rabbit hole here. Where are you gonna check hemoglobin, are you gonna check potassium, are you gonna do blood transfusion, like, how are you gonna go about this? Because none of this is comfort measure here. Unless you're doing for transplantation, which makes patient comfortable, that makes sense too. Right, because then it's not hospice. If you're gonna do everything what you do for dialysis patient, then there is no comfort here, right? That is not comfort, it's for hospice, they say cured, should have been cured. Apart from that, it's okay. Anything that prolongs life, cured, more than prolonged. But this prolonged survival. Anyways,
We're almost.
A lot of things in the VA don't make sense.
no, I mean, when you get enrolled in hospice, my point is what's their goal? Their goal to be comfortable, then you'll be everything against comfort.
People are scared.
So short
Doctor,
term goal is to finish it by once.
Okay, go ahead, go ahead.
We're almost done. I'm not going into depth on this one.
Okay.
The reason I brought this slide was more so for the fellows in terms of how to start up or the roadmap of end of life care
Career
discussion.
in hospice. There's a certification for that.
More or less,
Hospice.
have the
nephrology.
discussion with the patient is stable, they're not actively decompensating. and then you revisit the topic over a period of time to confirm their goals. That's more or less what this was. I'm just gonna go to these. Okay. All right, so key points. Obviously, there's a difference between palliative care and hospice and what they have to offer the patients. Palliative care availability resources are increasing nationwide, but they're still not meeting the needs of our patients. Patients have an increased mortality the longer they're on dialysis, and especially if they're older and have comorbid conditions. Nephrology fellows and then the new grads are feel unprepared to lead an end-of-life discussion, while patients feel as though they're uninformed about their prognosis and current state. And then there's a discordance as we discussed. And that's it.